Good morning. I'm Josef Rösch, and I will present my lecture, The Early Years and the Future of Interventional Radiology. I prepared this lecture for the 2003 CIRCE annual meeting in Antalya, Belek, Turkey. I am from Portland, Oregon, Oregon Health and Science University, and I work in research at the Daughter Interventional Institute. To start my presentation, I want to thank Professor Andy Adam and the other members of Executive Committee of CIRCE for establishing the eponymous Josef Rösch Lecture at the CIRCE annual meetings. It is a great honor and distinct privilege for me to have this lecture in my name, and I'm accepting it with pride, humility, and appreciation. I certainly appreciate that the lecture was established while I am still alive, and that I can be the first speaker. In my presentation, I will show many interventional pioneers in their early years, but the pictorial display will be biased and historically far from complete, as it is based on my own personal memories and documented only by photos that I was able to obtain. Interventional radiology developed from modern diagnostic angiography, which had its origin in Sweden in the 50s. It started with Seldinger's introduction of his ingeniously simple technique of percutaneous catheterization in 1953, and Erdmann's development of radiopaque catheters in 1955. Swedish angiographers, including Boysen, Olsen, Erdmann, Bergstrand, Lundekvist, and Paulin, then defined catheterization techniques and angiographic appearance of organ pathology. In the 50s and 60s, Sweden was angiographic center of the world, and quite a few future pillars of interventional radiology went there for long-term fellowships, including Abrams, Judkins, Wallace, Reuter, Braun, and Redman. For me personally, I was working beyond the Iron Curtain in Prague. Angiographic literature was my main inspiration. My first angio technique, transparietal splenoportography, was inspired by papers of Abbeatici and Campi. For visceral and particular pancreatic angiography, I relied on papers from Erdmann. I worked hard, and my books on these topics caught the attention of Charles Dotter. He invited me for a fellowship in Portland, Oregon, where I arrived in 1967. In 1968, when so-called friendly armies occupied Czechoslovakia and crushed the Prague Spring, I decided to stay with my family in the United States. And now to the main topic, to interventional radiology, which was conceived by Charles Dotter, my close friend, with whom I worked for almost 20 years. He first spoke about it officially on June 1963 at the Czechoslovak Radiology Congress in Karlovy Vary. On invitation from Professor Baštecký and me, I was the Congress secretary. Dotter presented a historic lecture there, Cardiac Catheterization and Angiographic Techniques of the Future. He concluded it with a historic statement. An angiographic catheter can be more than a tool for passive means for diagnostic observation. Used with imagination, it can become an important surgical instrument. Soon afterwards, on January 16, 1964, Dotter treated a patient scheduled for leg amputation for a focal arterial stenosis using coaxial catheters. After successful dilation of the stenosis, the leg circulation improved, gangrenous foot healed, and the patient left the hospital on both feet. The catheter therapy, transluminal angioplasty, as Dotter called it, was born on that day. The term of interventional radiology was coined by Margulis, who stressed special training, high technical skills, clinical knowledge, and care for patients as basic requirements for interventional radiologists. Dotter's idea that catheters should replace scalpels inspired inventive angiographers to develop new interventional techniques and tools. Werner Postman pioneered percutaneous closure of patent ductus and saved many patients from surgery. Kurt Amplatz, a great pioneer of cardiac angiography, developed many tools for interventions, including guide wires, catheters, foreign body retrievers, and devices for closing cardiac defects. Cesar Gianturco, a creative genius, gave us many tools of trade, including occlusive coils and IVC filters. Support from the industry, particularly from Cook Inc. and Meditech, accelerated the development of tools and devices. Each interventional techniques had its pioneers. In PTA, Dotter, Zeitler, and Grunzig were the early pioneers. When angioplasty fell on hard times in the US, Zeitler helped to spread the technique in Europe, and European interventionalists were daughtering diseased arteries. When Nandel improved PTA by introducing long taper dilation catheters, Postman developed a corset or cage catheter consisting of a latex balloon inside a Teflon catheter with longitudinal slits. The major revolution in PTA was initiated by German cardiologist Andreas Grunzig, who introduced balloon dilation catheter made of polyvinyl chloride. He first used it for peripheral PTA, and with balloon improvements, he extended PTA to coronary arteries. Grunzig's work inspired angiographers all over the world. Albert introduced his reinforced high-pressure telescopic balloon catheter. Matthias extended PTA to carotid arteries, and Horvath underlined the need for a combination of PTA and drug treatment. Other angiographies popularized PTA: Belan, Geoffrey, Lama, Rabkin, Riekers, Reedy, Simonetti, Stuyven, and others in Europe. Katzen, Campi, Motargemi, Ring, Schwarten, Sauce, Tegmeyer, and Woltmann in the US. The technique of selective clot lysis was introduced in 1972 with objective to treat complications of angiographic and PTA. Good results in our patients enabled us to enjoy peaceful weekends on mountains. After our paper in 1974, there was quite a bit of hesitation in using streptokinase in spite of good experience of Zeitler, Katzen, Van Breda, Becker, and others. Only after introduction of urokinase, local thrombolysis took off, with McNamara, Buchstein, and Kandarpa as its main proponents in the US. In GI bleeding interventions, Baum and Nussbaum introduced selective vasoconstrictive treatment, first for varicose bleeding, and later extended it to arterial bleeding. In our patient with bleeding ulcer and coagulopathy in 1970, in whom bleeding stopped only during infusion, we use arterial embolization. A blood clot injected into the gastroduodenal artery stopped the hemorrhage. After publication of our experience, arterial embolization took off, and Mellan in Europe and Athanasoulis, Buchstein, and Reuter in the US were among its pioneers. For treatment of varicose hemorrhage, Lunderquist in 1974 introduced an effective technique of direct transhepatic varicose embolization, and Keller, Tillen, Passariello, Uflacker, and Viamonte were among the main advocates of this technique. And then came TIPS. Here is the first experimental TIPS done in 1968 by a UCLA team. The idea of TIPS started with incidental punctures of hepatic portal branches during diagnostic transjugular cholangiography. After development of experimental transjugular portography, we export TIPS in dogs using different types of non-expandable tubings. We achieve patency for up to 2 weeks. The available small diameter tubings later occluded. We concluded that the TIPS is a feasible technique, but technology available at the time didn't allow its clinical introduction. Dotter and Keller also couldn't achieve longer patency of their experimental TIPS, even when they created large shunts with drilling and cryoprobe. Introduction of balloon catheters brought better results, and experimental TIPS of Gutierrez and Burgener stayed patent with repeated dilations for up to 12 months. These results encouraged Colapinto to perform the first clinical TIPS by continued 12-hour balloon inflation that resulted in significant portal decompression. He also had good immediate results in the other patients, but rebleeding in most of them showed that simple balloon dilation is not sufficient for prolonged portal decompression. In the mid-80s, Palmas made the final step in TIPS development with introduction of balloon expandable stent to keep the shunt open. In most of his dogs, the TIPS exhibited long-term patency. We also had early good results with TIPS in our young swine using modified Z-stent, but the parenchymal liver ingrowth prevented long-term shunt patency. The first clinical TIPS with stents was performed in January 1988 at Freiburg, Germany, in a patient with varicose bleeding and massive ascites by Richter, Palmas, Nolje, and Ressle using Palmas stent. They used the transjugular approach for hepatic vein catheterization and transhepatic approach for portal vein catheterization. A transhepatically introduced retrieval loop served first as a target for the transjugular liver puncture. The guide wire was then snared and held fixed for balloon dilation of the puncture tract and placement of 2 stents. The first tip was technically successful, but the patient died later of ARDS with patent shunt. They had better results with their following patients, and one of them lived with a patent shunt for more than 8 years. The pioneering work of the Freiburg's group inspired many interventionalists, and Benanati, Bilbao, Craina, Laberge, Maynard, Ring, Rousseau, and Zemel were among interventionalists who introduced the tips in their countries. We did our first clinical tips early in 1990 and helped in disseminating tips in Japan and China. Moving from tips to percutaneous embolization, which was first used for treatment of spinal and soft tissue AVM. Its pioneers, Dapman and Newton, used autologous clot. Because of fast clot lysis, Ginjan and Merlan in France introduced Gelafone, and Kerber in the US acrylate glue as embolic agents. Serbenenko in Russia then introduced detachable balloons, which were used mainly in neurointerventions. White in the US found the detachable balloons very effective also for embolization of pulmonary LVM. Ginter in Europe used mainly Gianturco coils in this indication. The spermatic vein embolization for treatment of varicocele was popularized in Europe by Kunen and Seidler, and by White and the Minnesota group in the US. Merlan was one of the first using uterine artery embolization for treatment of fibroids, and his group published the pioneering paper in 1995. Goodwin and Spies pioneered this technique in the US. In malignant tumor embolization, the Houston group under Wallace's leadership pioneered several very effective embolization techniques. In Japan, Yamada and Uchida introduced embolization of hepatomas and successfully treated even large tumors. Allison, Hemingway, Kaufman, Keller, Lang, Park, Tan, and Yaques were among the most active advocates and helped in worldwide dissemination of percutaneous embolization. Let us look at expandable stents. Their history started with the introduction of a coil spring tube graft in 1969 and accelerated in 1983 when Dotter and Craig introduced expandable 19-0 stents. Other stents rapidly followed. Palmas introduced his balloon expandable stent. Wall stent, the self-expandable Medinven stent that is known now as wall stent. Gianturco introduced the self-expandable Z stent and the balloon expandable flex stent, and Strecker his balloon expandable tantalum stent. Parodi then introduced stent graft into clinical treatment of abdominal aortic aneurysm. Innovative interventionalists introduced the new devices rapidly into practice and became pioneers in their clinical applications. In vascular stents and stent grafts, Ivanchev, Geoffrey, Lammer, Learman, Matthias, Richter, Rousseau, and Forwerk were among the first clinical pioneers in Europe. In the clinical introduction on non-vascular stents and stent grafts, Adam, Bezzi, Zwickel, Ivanchev, Lammer, Learman, Rossi, and Zollikofer did great pioneering work. In the area of biliary interventions, Berhini was one of the first pioneers introducing biliary stone removal and treated many patients, including the Shah of Iran. Adam, Cope, Kunz, Lunderquist, Ring, and Rossi then contributed by development of special tools and techniques and helped in wide dissemination of biliary interventions. In the uroradiologic interventions, Amplatz, Castaneda, Ginter, Hunter, Ruby, and Lang were among the first innovative developers of interventional tools and techniques. Fallopian tube precanalization was introduced in 1987 for treatment of infertility. This first successfully treated patient, in whom tubes were opened by simple flushing, didn't get pregnant. But one of the next patients, a wife of a physician, where tubes were opened by guide wire manipulation, got pregnant, and their article in Los Angeles newspaper brought us quite a few referrals from California. Kalekis in Europe, Lang and Roberts in the US, and Mahan in Canada have been among the main torchbearers of this technique. In addition to the mentioned pioneers, there were many interventionalists who introduced and pioneered interventional procedures in their countries. In Western Europe, Amiel, Barth, Becker, Bigot, Dondolinger, Essinger, Kurziel, Zepinets, and Ries were among the most active interventionalists. Boysen, Enge, Eriksson, Goetlin, Hegedus, Lerum, and Tillen were among pioneers in Northern Europe. Brett, Hausegger, Münster, Peregrine, Seibel, Sorensen, Steinhardt, and Trojanowska in Central Europe, and Bessim, Di Guglielmo, Feltrin, Obres, Pavchnik, Pisco, Rios, and Rosenberger in Southern Europe, Israel, and Turkey. Many of the pioneers and torchbearers were on the faculty of the Western Angiographic and Interventional Society meeting in Portland in 1993. In addition to pioneers, interventional societies including SIR in the US, JSAR in Japan, and CIRCE in Europe deserve great merit for worldwide dissemination of high-standard interventional radiology. SIR in the US was founded in 1973 under the leadership of Baum and Athanasoulis and had 28 founding members. The Japanese Society of Angiography and Interventional Radiology was founded by Hiramatsu, Uchida, and Yamada with help of Takahashi, Tamaki, and Morita. Han, Park, Ten, and Thompson have been leaders in Asian Pacific Interventional Society. In Europe in the 70s, there were two societies, ESCVR, an open society established by Eriksson and Pinet, and a close academic society, ECA, with early leadership of Boysen, Fuchs, and Lunderquist. Both societies had a joint meeting in 1985 in Vienna under the presidency of Olbert, with Allison, Rosenberger, Rossi, Struiven, Zeiter, and Zollikofer among scientific committee members. The meeting was very successful with a high-quality scientific program, and after friendly discussions in official and private meetings, Albert toasted the establishment of the combined society CIRCE. Many prominent European interventionalists have participated in leadership of CIRCE, which is now the second largest radiologic society in Europe with more than 1,500 members. And now to the future. Presently, interventional radiology has come of age and is a recognized subspecialty in medicine and is used in diagnosis and treatment in practically all systems and organs of the human body. Not all, however, has been going well in interventional radiology. The interventional turf got crowded, and interventional radiology is being constantly encroached upon. We are losing procedures that we developed. There are frictions with our diagnostic colleagues, and the public doesn't know who we are. Briefly, what do we need to do? We need to establish our own specialty and assume clinical responsibilities. We must admit, evaluate, treat, and follow up our patients. Be real doctors. To be able to do it, we need to change the training with shorter imaging, extension of interventional training, and inclusion of clinical and surgical training. We also need to form close partnership with clinicians in the form of centers. Does it seem impossible? Of course not. As the rocket scientist Bob Goddard said, it is difficult to say what is impossible, for the dream of yesterday is the hope of today and reality tomorrow. And as I am saying, determination, resiliency, hard work, and diplomacy when needed will help you to achieve your goals. And you have my best wishes for your endeavors in preserving and improving interventional radiology. Thank you.